Department of Psychiatry, GMC Srinagar. So as we all know, this month of October is celebrated world over as Breast Cancer Awareness Month, and we have did our part in this month to organizing this webinar, so that we can do our part regarding this issue of public health importance, of great public health importance. So I would like to first of all introduce you to what sessions we're going to have. We'll first of all opening session will be held with our HOD, Worthy HOD, and Principal Government Medical College. Then there will be technical sessions. Technical sessions will be chaired by the speakers in the technical session will include the Dr. Shamima Akhtar. She's Assistant Professor Surgical Oncology and is in charge HOD Surgical Oncology. She will be talking about awareness and overview of breast cancer. Then we have Dr. Muhammad Altaf Hakim, is a consultant medical oncology and is in charge HOD medical oncology. And also we have Dr. Sadakat Rahman, Assistant Professor from Clinical Psychology from the Department of GMC Srinagar. So to begin with the session, I would like to welcome and invite our worthy, dynamic, visionary HOD of the Department of Community Medicine, Professor Dr. Muhammad Salim Khan. Sir, kindly just grace the event with your auspicious comments on opening comments and the keynote address. Over to you, sir.
Assalamu alaikum and very good afternoon to all the participants here. It's our endeavor and our mandate also that Department of Community Medicine should reach the stakeholders and public through nowadays through the media of these webinars, so that we reach people with knowledge and make them aware of the current scenario, especially the diseases which have reached higher levels in the community. As nowadays we see the pandemic of SARS-CoV-2, and previously we had some sessions on that. So our department's endeavor is that every month we should have one webinar based on the theme for that particular month. We started with FOPL. Then last month we had a webinar on rabies on occasion of World Rabies Day. Today, during the Breast Cancer Awareness Month, we are having a webinar today, and I would like to say that we couldn't get the best persons around than those who are in the panel of speakers in here among who are presenting the webinar today. And secondly, the host for the program, Dr. Kaunsal Siddiq, has worked during her post-graduation on breast cancer. I believe we don't have a better person in the department to speak on breast cancer, as she had worked on it at least for 2 to 3 years. So my best wishes in organizing this program. As we know, this year, the theme for Breast Cancer Awareness Month is RISE. That is rally in supporting, serving, and screening everyone. So as we see over many years now and decades, that number of cancers have gone quite high, especially the breast cancer. We see the age of menarche has gone down. So we see girls getting menarche quite early, and the reproductive age group is widened. And secondly, once we look at the mothers who just stop breastfeeding, they are at high risk. The obesity, and the lifestyle changes, especially decreased physical activity, high fat intake, all these are contributing factors to cause breast cancer. And nowadays we see these trends quite common among our young population. So along with this webinar, I suggest that we should reach the school-going and college-going girls in their schools, colleges, and universities, and make them aware about the cancers and about the preventive measures that would help them to stay away from risk factors associated with breast cancer. I thank Dr. Kaunsal Siddiq for organizing this webinar, and I welcome all the participants or guest speakers, Dr. Shamima, Dr. Altaf, and Dr. Sadakat Rahman Drabu. I acknowledge your presence in this webinar, and more importantly, I thank our worthy Principal Dean, Professor Masood Tanvir Saab, for sparing his time to grace the occasion and inaugurate the session. Thank you, Dr. Council.
Thank you, sir. Thank you, sir, so much for your graceful comments. Now I would like to invite and welcome our worthy principal, Professor Dr. Tanveer Masood, to grace this event with his admirable comments and inaugurate this webinar for us. सर आ रहे हैं क्या? सर आ रहे हैं क्या? Kindly wait for a few minutes. We're just trying to connect with the principal's office.
You should unmute nation kareni. That was actually muted. That was actually muted. Okay. Am I audible?
Yes,
You're
sir.
audible. Yes,
Yes,
sir.
sir.
Thank you.
Thank you. Thank you, Dr. Professor Salim Saab. Thank you, the organizers and the participants. On behalf of GMC Srinagar, I welcome you all. And I would like briefly to share some of my thoughts with the participants. Overall, the cancer incidence as well as mortality is increasing throughout the world. And in 2020, we had 1.9 crore cases, new cases in the world. And in 2020, we have had 10 million, which is around 1 crore cancer-related deaths. The second point I want to make is that female breast cancer is now the #1 diagnosed cancers in the world, and it has recently surpassed the lung carcinoma as the #1 diagnosed cancer. So it has displaced lung carcinoma and has now become the leading cause of newly diagnosed cancers. This is not to differentiate it from cancer-related deaths, where lung carcinoma still is the #1, along with colon, liver, stomach, etc. And lung cancer is one cancer where there's an increased incidence in countries with high HDI, which is the Human Development Index, with the highest rates being reported from Australia, New Zealand, Western Europe, North America, Western Europe, and very low, rates in countries from Africa and Asia. But since Asia houses the majority of population in the world in terms of numbers, Asia is important because it houses the maximum number of breast CA cases because of the population in India. And the difference between the two countries, the rich countries and the not so countries, is that mortality of breast cancer is much higher in developing countries as compared to developed countries. And in this context, October month is celebrated every year as the month of breast cancer awareness. And the idea is to create awareness among the public as well as among healthcare workers, so that it promotes knowledge about breast cancer, and that will lead to early detection, and early detection will lead to early referral will lead to early treatment, and early treatment will lead to better survival. And WHO aiming to reduce the mortality related to breast cancer by 2.5% every year, so that we'll be able to save maybe around 2.3 million lives in the next 10 years. So this is a very noble cause, and I thank all the participants as well as the organizers. And with these words, I would like you to begin the session. May God bless you all. Thank you.
Thank you very much, sir, for inaugurating the session. It's under your dynamic leadership and mentorship that we are able to conduct this program involving all other departments of GMC Srinagar. Thank you, sir.
Thank you. Thank you.
May I request everyone to have their video on so that we have a snapshot of the webinar and then we will move ahead. Requesting everyone to have video on for a while.
Thank you so much, sir. Our worthy principal, thank you so much for this arousing session and for giving us opportunity to be here with you in this webinar session. Now I would like to begin with the technical sessions. So let me start with the session regarding the overview of breast cancer as a global health issue. Like already Dr. Munish, our worthy principal has already aroused us about this issue, how breast cancer is an budding issue and how it has become the most common cancer in the world in recent years. So let us talk about that global issue of breast cancer. Screen share हो रहा है?
Not yet.
Dr. Council, move ahead.
Wait.
Thank you, sir. Thank you. So we will continue.
Thank you, sir. Thank you so much.
Okay.
Screen share हो रहा है. ये है ना?
Dr. Council, हाँ, screenshot ये आ गया. Screen share, please continue.
Okay, thank you. So, like if we look at the numbers in current years, so in 2020, breast cancer has become the most common cancer in both the genders, and in females, it was already the most common cancer diagnosed. Around 24% of all the cancer diagnosed in 2020 in females was breast cancer. So in males also, it was around 11.7% of total cancer cases. In total, in both the genders, it was around 11.7%. So it has now surpassed lung cancer, which was previously the most common cancer in the world, but now it has been taken up by breast cancer. So the statistics say that 1 in every 4 cancer cases are breast cancer cases, and 1 in every 6 cancer deaths is due to breast cancer. So that is a huge number in itself. If we look about the burden of different continents and countries, so most of the burden comes from Asia. And in Asia, most of the burden is coming from China and India, so which is a thing of concern for us. So 12% of all new annual cancer cases worldwide, according to WHO, are because of breast cancer. So, and most common cause of cancer death in women is breast cancer, and it's the 5th most common cause of cancer death overall. So, but the burden of mortality is borne mostly by the lower and middle income countries. And around 500,000 of women have died in lower and middle income countries due to breast cancer in 2020. Now, if you look about the Indian scenario, in both the genders, again, breast cancer has become most common cancer. If we take overall cases in both genders, breast cancer has become the most common cancer recently. which was taken earlier by lip and oral cavity, but now it is breast cancer in India also. And if we look about females, in a few years back, cervical cancer was the most common cancer among females, but now this position is also taken about by breast cancer. So overall, in nutshell, globally as well as nationally, breast cancer is the most common cancer. It has evolved in very, very fast in recent years. And if you see this map, it is showing the all the countries with which is the top cancer in all these countries. So we see whole of the world is pink. That is depicting breast cancer is the top cancer in almost all the country except a few. So now if we talk about a scenario in our Kashmir, so we don't have that much reliable statistics in Kashmir because we are having only one regional cancer center in Kashmir, that is in the SKIMS, and they are having the regional cancer registry. We don't have a population-based registry. So whatever statistics we are having, it has not been done. The recent statistics have not been, they have not come up. So we know that breast cancer is the second leading site of cancer in female based upon the past records and based upon the research done till now. And if we talk about overall genders, if we talk about among all the cancers, it is second most common cancer in the world. So thank you all for being with me in this session. Now let's move forward into the next session, which will be taken by Dr. Shamima Akhtar. She's assistant professor and in charge HOD Department of Surgical Oncology, GMC Srinagar. She will be talking about awareness and overview of breast cancer. Over to you, ma'am.
Thank you. Am I audible?
Yes, ma'am, you're audible.
Thank you very much. Assalamu alaikum and good afternoon. So thank you, Department of Preventive Medicine and HOD Department of Preventive Medicine, giving me a chance to speak on this awareness of breast cancer. Let me start with the cancer. If we see cancer, globally, burden of the cancer has risen to about 20 million. And about 10 million deaths we can see, and International Agency for Research of Cancer has estimated that 1 in 5 men and 1 in 8 men will develop cancer in their lifetime, and about 1 in 8 men and 1 in 11 women would die because of the cancer in their lifetime. And what's the reason? And the reason of these cancers and these deaths due to the cancers is socioeconomic features, lifestyle changes, infections which have arisen, then exposure. So these are the reasons. And to overcome these reasons, so we have these awareness plans which we then promote to their populations. And let me start with the breast. And as already has been stated, this is the most common cancer diagnosed in females nowadays. And this is the second most common cancer leading to death in females. So to overcome these things, we can work on it. We can provide the measures like early detection and awareness programs. For early detection, before that, we can do some preventive measures. So how can we do these preventive measures? Am I audible? The preventive measures are first we act upon the prevention, maybe by primary prevention, by secondary prevention, or by tertiary prevention. Primary prevention starts with these preventable risk factors. We have preventable risk factors like dietary factors. So unhealthy diet is the most common cause, and WHO has reported 1 in 10 cancers will be because of the unhealthy diet. So we have to act upon the diet, and then obesity. So again, being overweight is a reason, it's a risk for cancer. So we should act upon our this obesity. We should avoid being overweight. So after that, the breastfeeding issue is there. So we should encourage our females to breastfeed their children. And after that, we should avoid alcohol intake. We should avoid smoking. And in addition to that, we should avoid the exposures, environmental exposures as much as we can. And after that, we should go for regular health checkups, because at the end, it's the regular health checkup which is important, which can prevent us from developing these cancers. Am I audible?
Yes, ma'am, you're audible.
Yes, thank you. So primary prevention is avoid these preventable risk factors, and then after that comes the secondary prevention. Secondary prevention is our goal. Actually, secondary prevention is we will start some screening programs. So what is screening actually? Screening means identification of unrecognized disease in an apparently healthy individual. So in breast, we have screening programs, and these screening programs are in breast, we have this screening program. Women between 20 to 39 years of age, we can do breast self-examination. It's optional. And then clinical breast examinations at least every 3 years. And the women who are more than 40 years of age, we must do breast self-examination and clinical breast examination annually and mammograms annually. So primarily, we have taken upon this clinical breast examination and mammograms, which we have to do annually. And what is this breast self-examination? Breast self-examination is a woman has to lie down and she has to palpate her breast, and then she has to stand in front of the mirror with her hands on the hip, and then she has to examine her breast. She has to look for the size of the breast. She has to look for any lump stains. She has to look for any asymmetry of both breasts. And third is she has to raise up her one arm, and with right arm she can examine, and she can repeat this on the other side same way. And then breast examination by doctor, she has to do it annually after the age of 40, and that will be examined by her clinician. Second factor of prevention is so one is self breast examination, and then there is self breast examination, and then there is another is examination by the clinician, and third is the mammogram. The mammogram is 2D mammography or a 3D mammogram. 2D mammography is available with us. Unfortunately, we don't have 3D mammogram available this time. So it has more. It is more sensitive and specific than 2D mammogram in identification of the diseases. We have a lot of myths about the mammogram, which we should explain to our patients that mammography does not lead to cancer. Mammography is not harmful. It does not lead to breast cancer. It's a bit painful now. The digital mammographies are not much painful. So after we have screened the patient, and we have screened the patient, then we have diagnosed some disease, then we can go for some treatment. So diagnosis of the disease is, once the disease is diagnosed with our clinical examination and with these tests, let me go to the risk factors again. I discussed modified Babel risk factors, and then the overall we see the general risk factors. The most common is actually age. Age is the most significant risk factor because as we grow older, gender is significant. If we live long enough, it's as said by Robert Winberg, if we lived long enough, we would develop cancer. Sooner or later, we would develop cancer. So age is a factor. More we get older, there are more chances of getting the cancer. Then gender, of course, everybody knows. Females are more common. It's only seen in 1% of males breast cancer. So after that, we have race. It has been seen more in whites than blacks. And if we see relations, so first degree relatives have more chances of getting cancer than second degree and third degree relatives. And after that, you will see the menstrual issue I discussed already. So early onset of menarche, late menopause, so increased gap of this exposure of female to hormones has led to more of cancers. And then females who have children, they have less chances than the females, and who have bear the children less than 30 years, they have less chances. And then the females who have conceived after 30 and who do not have children at all. In addition to that, obesity, we already discussed with it, and then discussed this factor. And then, of course, the diet, intake of fat, intake of alcohol, less intake of vegetables, less intake of fruits, and lack of physical activity and the stress, which we are these days, which is more being seen. And then the exposure, especially the exposure of radiation, and the patients who have history of breast cancer, either in the patient self and the family, and then intake of hormones during their lifetime, especially in their post-menopausal time. So once these risk factors have come and then patient has developed a disease, she can come with you some symptoms, and the symptoms may be a persistent lump in the breast. She may feel a persistent lump in the breast or thickening in the breast or in her armpit or in his armpit. And then there may be a color change in the breast, like change in the color of the skin, or there may be change in the color of the skin of the breast, areola or the nipple. There may be some dimpling, puckering, there may be some scaling. Patient may see like there is nipple has inverted, and this is a recent inversion of the nipple, or it may be retracted nipple, pulled in nipple. She may notice an unusual discharge from the nipple, which may be in the form of serous discharge, dirty discharge, or a discharge of the blood. And discharge of the blood is more serious than other discharges. Or she may find a change in size and shape of the breast. One of the breasts has become larger, it has become harder. There may not be any lump, but there may be change in the size of the breast. So, okay, now symptoms have come. How to diagnose this breast cancer? Diagnosis starts with this clinical diagnosis, like as I said. As I said, there may be change in the color of the skin, there may be ulceration, there may be inversion of the nipple, there may be enlargement of the breast, there may be dimpling of the skin. After this, we will go for diagnostic tests. The diagnostic, as I said, clinical has gone, and then there may be, we will do some imaging methods, and then we'll do some biopsies. Imaging involves, the first imaging is mammography. So we will order a bilateral mammogram. Once we have ordered a bilateral mammogram, we may identify a speculated lesion in the breast in a cephalocaudal view, and we'll observe the same lesion in the mediolateral view, and then we may identify a lesion in the breast, hyperechoic lesion, which may not be typically speculated, which may be reported as BIRAD 4A-B by the radiologist. So again, as per the BIRAD system, we have to act upon these lesions. Like if it's BIRAD 1, we don't have to do anything BIRAD 1 for BIRAD 1 and 2, and for 3 we may do a follow-up. For BIRAD 4 lesion, which is a suspicious lesion, we must go for a biopsy, and of course BIRAD 5 is biopsy is to be, for a BIRAD 5 lesion, biopsy is to be done. And then after the ultrasound, if we have some doubts, we can go for ultrasound of the breast. It may increase the sensitivity. It will in fact add upon the findings of the mammogram. If we have some confusions in the mammogram, like you can see in this ultrasound, there's a dispelucent lesion, hypoechoic lesion in the breast, which was detected in the mammogram, and you can see it in the ultrasound. And after ultrasound, we can go for MRI. MRI has a specific role. We don't do it more often. We do it MRIs if our patient if there is some doubt in the mammogram, ultrasound, then we go for MRIs. And especially we do MRIs if patient wants to undergo breast conservation surgery. So that has its own indications. After the MRI, we have done this. We go for some staging procedures. In staging procedures, we can do CT scan, and then after CT scan, we can order CT scan, bone scan, or more of we can order the PET scan. And once we have done these imaging procedures, we will do the biopsy. Biopsy may be in the form of for FNAC, excision biopsy, incision biopsy, Rucker biopsy. Rucker biopsy is a standard procedure which we do nowadays. Is the standard procedure which we do nowadays, and biopsy is mandatory to get the histopathology, to get the immunohistochemistry, and to finalize the treatment. Now we have done the biopsy, we have done the imaging, and finally we have to stage the stages. So staging, everybody knows for the breast, we have stage 1, 2, 3, 4, 5. The only specific thing in the staging here is, previously we used to say a supraclavicular node is a metastatic disease, which has been changed in AJCC 9th, that it is not a metastatic, it's a N3 disease, so it comes in 3C. So this is a change which I am putting over here, that N3C, like supraclavicular node, ipsilateral supraclavicular node is not a metastatic disease now. It is a stage 3C disease. So we can give treatment as per, and we can give curable treatment to these patients rather than giving them palliative treatment. So going to the treatment of the breast cancer, we can go for surgery, we can go for radiation therapy, we can go for chemotherapy and hormone therapy. So which patients need surgery, which patients need radiation, which patients need chemotherapy and hormone therapy. Grossly, we can say patients with stage 1 and 2 can undergo surgery. Patients with stage 3 disease they have to go for the chemotherapy followed by the surgery. And of course, the stage 4 patients, they may go for palliative chemotherapy plus minus hormone therapy plus minus surgery. The surgery may be in the form of lumpectomy, or modified radical mastectomy, or lumpectomy, simple mastectomy, modified radical mastectomy, or radical mastectomy. Rarely we can go for the reconstruction. And then the chemotherapy, just an overview of the chemotherapy. As I discussed, the chemotherapy, as per the age, we give chemotherapy. But in general, chemotherapy, every patient needs chemotherapy when the size of the lesion is more than 0.5 centimeter, irrespective of anything, node positivity, node negativity, and irrespective of the hormone status, HER status. Patients with tumor more than 0.5 centimeter need chemotherapy, except age of more than 70. If they are hormone positive, we can avoid chemotherapy in them. We may avoid chemotherapy in them. And going to the hormone therapy, all the patients who are ERPR positive, estrogen receptor positive, progesterone receptor positive, they will need hormone therapy for a period of 5 to 10 years. And then targeted therapy in the form of Herceptin, who are Herceptin positive. Going to the radiation, who needs the radiation? So patients who have undergone lumpectomy, the rest of the breast has been saved, so they need radiation therapy for the breast. That will be standard radiotherapy. And then patients who have undergone mastectomy, why do they need breast? When do they need radiation therapy? And the radiation therapy will be given for the lesions which are more than 5 centimeters, and lesions which have involved skin, lesions which have involved chest wall, in lesions where nodes are positive. And for this is after the mastectomy. And radiation will be needed if we have done sentinel node biopsy only, and we have identified micrometastasis in nodes or macrometastasis in nodes. For macrometastasis, again, you can go for axillary lymph node dissection plus minus radiation, or for micrometastasis, you can go for radiation only. If we will go for prognosis, overall the prognosis of this, so stage 1 disease is 85 to 90%, stage 2 disease is 70%, stage 3 disease is 55%, and stage 4 disease is 5%. Then we have myths and facts about the breast cancer. Myths and facts of the breast cancer, like touching the breast too often will lead to cancer. It is being said by the females usually. Talking about the cancer will cause cancer. Using illegal drugs will cause cancer. Herbs will cure the cancer. This is not like that. A bruise on the breast will lead to breast cancer. If an incision is made during breast cancer surgery, it will lead to cancer, which is the common myth. Like if you make an incision, it will spread the cancer. Getting too many mammograms will lead to the cancer. Mammograms are only used to evaluate the lump. No, mammograms are used to screen the breast. And after that, they are used to evaluate the lump. First, they are used to screen the breast. Thank you.
Thank you so much, ma'am. Thank you so much for this arousing and impressive session on breast cancer and its clinical aspects. Thank you, ma'am. I would now like to invite and welcome Dr. Mohammad Altaf Hakim, who is consultant and in charge HOD Department of Medical Oncology. And He will be talking about the clinical aspects of breast cancer cases and discussion of unusual case presentation. Over to you, Dr. Altaf, sir. आवाज नहीं आ रही म्यूट.
Bismillahirrahmanirrahim. Assalamu alaikum. At the onset, I would like to thank Professor Salim Saab, who has initiated this scientific endeavor, and definitely very much thankful to Dr. Komsar, who dragged me to present it, because I had left presenting for the last 2 years. So I will discuss this little bit of scenario in our valley of the breast cancer and some clinical behavior of the breast cancer tumors in our setup. Okay. Going to background and introduction of the breast cancer, we have been having a good survival and good follow-up of the cases. But the survival and this good response is becoming a complication for us, because there are more recurrences, more incidences, and more. So there are some factors which has added up the breast cancer incidence, like late marriage, which is in a dictum today, where there is a hormonal changes, like other lifestyle, which has increased this. There's a little bit of clinical story in India. We have total cancer cases in India. Incidences in males 94 and 103 in females. That means we have 13 lakh, or 1.3 million cancer cases in India in 2020, out of which we have breast cancer in 1,62,000, and mortality of the breast cancer is 87,000. That means this is the second most common cancer in India as well as other countries. And we expect 2025 we will have 15.7 lakh breast cancers. Going to the causes of the cancer, breast cancer, 10% are hereditary, and 90% will depend on lifestyle, that is obesity, unhealthy diet, alcohol, exposure to radiation, chemicals, estrogens, hormones, late menopause, repetitive history. I would like to show you some clinical differences and clinical changes we have in breast cancer. Most common ductal carcinomas, which constitutes the 80%, and 10 to 20% are lobular carcinoma. But in between, there are some 5% of cases of other histologies, which we also encounter in our day-to-day practice. For example, this is the patient who had an BIROD 4 globular mass. I will tell you what happened to him on mammogram. This is the other patient who was moving from pillar to pillar for 3 months in order to find out a diagnosis, because the nature of the breast cancer is same. It is an inflammatory breast cancer. He did 3 biopsies which were negative. After doing 3 biopsies, we did an MRI. We showed some definite finding, and we came to a conclusion what kind of is this. I'm giving a brief some cases what will happen. Dr. Kausar told that we don't have this breast cancer registry. We have. This is not the case, as our oncology department was started in 2006. Subsequently, it divided into two in 2014, that is medical oncology and radiation oncology, and it is making the case registration on a regular basis. You can see from this chart that in medical oncology, we had 490 cases in 15, and this year up to October, we have 623. And we have been shaking all the cases, trying to find out what are the different varieties of the breast cancer malignancies in these. We had 4 cases of pregnancy-associated breast cancers, which were treated and which were maintained also. We had one with this is the other study which is from radiation oncology department, which was done in 2010 and 2011, and definitely 64 and 66 breast cases, and it remained in the 10% to 11% throughout. The youngest patient we had 22 years and oldest we had 90 years. So overall is 11%, which I have already told. We had some atypical histological finding cases. That we had a primary lymphoma of the breast, which is published in the journal. We had an oculate male breast with second malignancy. We had a primary liposarcoma in the male breast. We had many inflammatory breast cancers, which are very difficult to diagnose and very difficult to treat. And we had 2 cases of TNB tumor, this triple negative breast cancer, which were found after surgery, because on the first surgery, they were found to have ER positive or HER2 positive. But after surgery, when the other metastatic sites were sent for this hormone receptor, they changed it, because it is usual that it happens. I have told you we had 4 cases of the breast cancers, and to tackle the breast cancer with pregnancy, it is a difficult issue. These are some drugs which we can give and which we cannot give during the pregnancy. 5-FU, capsaicin, irinotecan we can give because they have a low molecular weight, but other which have a high molecular weight, it is very difficult to give those drugs during the malignancy. This is a case of the breast cancer with pregnancy. This is really a typical case position. She had a first. She was a 30-year-old lady which came to our department. I was in the joint department of radiation oncology and medical oncology at 2011. She presented us with axillary lymph node, and she was excised, and she was subject to MRM, followed by AC and Taxol 4 cycles radiation 1 year. She was ERPR negative, and after 1 year receiving the treatment, she conceived and delivered a baby. Then in 2017, she again came, and with a lump in the breast, we investigated her. This was after first treatment, and after she delivered, and then again she came with a lump. What happened? Second malignancy is a metachronous. Metachronous and synchronous means when the other lesion will appear in the other breast after some time. When synchronous, they present simultaneously. So this was a kind of metachronous bus lesion which was in the right breast. First was in the left breast. On immunohistochemistry, she came TNB. That means she changed her positive to her negative. This happens in the course of time when we have a long follow-up after the disease. They have a different types of mutational changes. She, in view of his TNB status, we gave her oral chemotherapy, which is a must for a patient with a TNB triple negative breast cancer. She received 6 cycles, and after 6 cycles, she came to after those 6 cycles of capecitabine, she had an amenorrhea after 4 months, and she was again on ultrasound pregnant. So she was receiving chemotherapy. She had been treated. She was again. Now the question was what to do, whether we should give the drugs or we should terminate her pregnancy. As I told, there are some drugs which we can give. I told her not to take drugs for 1 month. So for 5 months, she carried the pregnancy. Unfortunately, she had to go for termination of the pregnancy. Now the question is, this is when she came 2011, she was fully recovered after some time, after for up to 11 to 17, and this is the mammogram of the 2017 in the right breast. She had developed a metachronous lesion. This is the lady. She presented us up to 2319, and she is doing well. This is the other metachronous breast disease. That means she had earlier disease in 2006, 3rd March, when she went, she was T2N2XMX left breast. She was subsequently started on chemotherapy CAP. First cycle was given on 28/4/6 and last was given 23/6. She was completely treated with all the 3 modalities in up to 2007. She was having some medical complications and hypertension and diabetes. In 2012, we did a mammogram, which was a normal. She did not turn up for 2 years, but in 2018, she came with an inflammatory region in the right breast. Breast has shown nipple discharge. CT scan showed heterogeneous right breast parenchyma. Mastectomy with Israeli reduction was done, and she was diagnosed at T4N2MX. That means in 2006, 1 breast was chopped, and then in 2018, again she went for another surgery, and treatment was again started. She received a EC, epirubicin and cyclophosphamide, and Taxol, which is a standard treatment in elderly patients. Overall, we had 4 cases of metachronous disease, 60-year-old lady and this 25-year-old CA breast with pregnancy. This is the CT scan of that elderly lady, which we did post his right breast pre-surgery 2018. You can see this. There's a lump. This is the breast lump, another breast, and you see the mammogram also. This is the picture of that lady. This both breasts are excised, and this is her histopathological diagnosis. This is a I had discussed with you that we had a tricky inflammatory breast carcinoma recently. This is her mammogram. They did 2 to 3 incisional biopsies, but because of the nature of the disease, they could not find anything. And at the end, we went with MRI. MRI showed dermal changes. Third time, with a quite specific maneuver, our radiology department people did an excisional biopsy and they found it is a inflammatory region. Then we sent it for immunohistochemistry, which came positive, and it is also a triple negative. They say this inflammatory breast cancer, which is a very rare condition, has usually triple negative breast cancer status, and this is very difficult to alter. You can see this mammogram of the same patient. The lining is this lining of dermal involvement. You can clearly find out on mammogram, which gives a confirmation that it is a inflammatory disease. Ultrasound, when we go to this inflammatory change, inflammatory carcinoma of the breast, they have a heterogeneous texture, subcutaneous edema, significant lymphadenopathy. This lady was other inflammatory breast, which was diagnosed and treated in our department. This is a slide shows the dermal involvement, which tumor the tumor emboli in the dermis, they are there. Inflammatory breast CT scan, no visceral mets there. We don't have a visceral metastasis. Bone scan is normal. Right suprachiasmatic lymph node is positive. Right inflammatory breast cancer is clinical stage 3rd. This is the other patient which was also inflammatory breast. This is the lady. We can see the dermal redness of the arm, scapula. This is the classical of this breast cancer, inflammatory breast carcinoma. Let me tell you honestly, this is when we were working in a Saudi lady with an intact breast with PD orange. This was also inflammatory breast. It is long ago, 20 years before slide, which I have got it. It was usually seen by Dr. Sharifa. This is the inflammatory breast cancer, how it presents when we go for discussion that it is a clinical pathological entity, skin is swollen. It was first seen by Tanim in 1924, misdiagnosed for mastitis, aggressive variant, rare 1 to 5%, age is usually 55 to 58. It is usually seen obese, high BMI patients, African Americans. Diagnosis of the IBC remains a clinical one. It goes away. Yeah. Diagnostic workup with inflammatory breast cancer is clinical examination, ultrasound, Doppler ultrasonography, mammogram, intraocular biopsy. MRI is must. Bone scan, and this is a normal thing. Biology of the breast cancer in inflammatory breast cancer means that, okay, there is a local recurrence, there is a metastatic high potential, and considered fatal in the past and aggressive nature. Now, what is the future of this inflammatory breast cancer? Ongoing research at molecular level uncover true biological nature, new treatment modalities, clinical trials, gene expression of inflammatory breast cancer. We have to find out response to neoadjuvant chemotherapy, anti-angiogenic and drugs like bevacizumab we give, high dose CT. Conclusion is rare aggressive highly clinical suspicion, multimodal treatment approach. Now, lastly, I will discuss, we had 2 cases of lymphoma breast, one female, which we chopped her breast and then it came lymphoma. She came with the brain metastasis and unfortunately she died. This is a lymphoma of the male breast, which after mammogram, we subjected her to, you can see that mammogram is showing a globular lesion here. When I saw this mammogram, I could depict that it cannot be a breast, any lesion of the ductal or lobular in the breast. We subjected her to the FNEC. Luckily, FNEC came with ductal carcinoma and lymphoproliferative disease. Then we did core biopsy. Core biopsy came as non-Hodgkin's lymphoma, and we have accordingly treated her. This is her treatment. We gave her R-CHOP, that means toximob and other treatment. Okay.
Thank you, Dr. Altaf, for this knowledgeable session. Yeah, after this session, I would like to make a point here, because Dr. Altaf has said in his presentation that GMC Srinagar has a hospital-based cancer registry. Actually, I was talking about a hospital-based cancer registry, which is registered under ICMR under the National Cancer Registry Program. Kashmir only has 2 hospital-based cancer registries which are registered under this program. That is, one is in KIMS and one is in GMC Jammu. The hospital registry which we are having here in GMC Srinagar, that is for only hospital records. That is not tagged or registered with the National Cancer Registry Program. So that is what I was talking. So that registry we don't have here, and we must work on that to have that registry in this.
No, that's fast.
So thank you, sir.
In fact, I had asked the government to make a state cancer register. Let it be population based. Let it be, because when we send them institute people, they come here, take data, but unfortunately, that then what happens, we are not able to know.
Okay, sir. No issue. Inshallah, we'll work on that.
Okay.
Will happen in future.
We have to find it out, and we have to cooperate with each other.
Thank you, sir. Thank you. Now, I would like to welcome and invite Dr. Sadakat Rahman, Assistant Professor, Clinical Psychology, Department of Psychiatry, GMC Srinagar, to aware us about the role of psychotherapy and psychiatric counseling in breast cancer patients. Over to you, ma'am.
अरे कोई बात नहीं, नहीं बंद रखा, 1 मिनट रुक जाओ। दी ये खुल ही नहीं रहा है, शेयर करो पहले।
बोलो, मैं शेयर नहीं कर पा रही। क्यों?
Yes, Dr. Sadakat.
Can
see you.
Okay.
Okay, ma'am.
Thank you so much, Dr. Salim and Dr. Kausar. I'm highly thankful to you. I'll present my topic. Today, my topic is role of psychotherapy and psychiatric counseling in breast cancer patients and their family. Like once the lady has a breast cancer, she loses her main part, and like we cannot return her part back, but we can maintain the quality of her life. Patients with breast cancer are susceptible to mental health problems such as anxiety, depression, neurocognitive deficits, hopelessness and uncontrolled pain, changes in body esteem, relapse of illness, suicidal ideation, loss of control, and sense of helplessness and death. So palliative care and psychological management, we can do. World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the associated with life-threatening illness through the prevention and relief of suffering, involves all stages of life. Threatening illness include psychological, social, spiritual, and cultural issues. Palliative care affirms life and regards dying as a normal process. Neither hastens nor postpones death. Provides relief from pain and other symptoms. Integrates the psychological and spiritual. Offers support system to help patient live as actively as possible. Help family to cope. Utilize a multidisciplinary approach to address the needs of the patients and their families. It's applicable early in the course of illness in conjunction with the other therapies that intended to prolong life. Psychiatry and palliative care working together towards a common goal. Palliative care goal is a relieve symptom and suffering and improve the quality of life for patient and their families. Palliative care informs psychiatry, assessment and treatment of pain, bereavement, anticipatory loss. Psychiatry informs palliative care, assessment of psychiatric illness and mental status changes, evaluation of capacity, psychiatric treatment, insight into personality, structure and communication issues, conflict and resolution. Role of a psychotherapy and psychiatric counseling. Like usually we give counseling to the normal patients, but like for the cancer patients, it is totally different. Overall psychological treatment goals help patients maintain control their lives. We can maintain the quality of a life of a cancer patient, but not his, we cannot stop his death or anything else. Assist in developing healthy coping strategies. Help control anger, denial, panic, despair, fears of rejection and abandonment. Help establish self-respect by assisting with resolution of guilt, shame, and blame. Help with communication and the maintenance of the support system. Overall psychological treatment goals are help maintain interpersonal relationship, help develop strategies of deal with the real and anticipated crisis, help identify the address unfinished business, work with patients to explore meaning to death. Like the patients, like who have cancer, they die before the death comes to them. So we explore the meaning of death, help manage depression and anxiety or other psychiatric symptoms that may make form psychological issues or effects of treatment. Dignity conservative treatment. Dignity therapy treatment is based on strong association with undermined dignity and depression, anxiety, desire of death, hopelessness, feeling of being a burden on others, because this patient always feels that he is burden on the others. So like we assure him, we give him therapies and dignity therapy in such a way that he doesn't feel that he is burden on others. Overall, poorer quality of life. Some studies even suggest that psychosocial and existential issue may be greater concern than pain and physical symptoms. Dignity conservative treatment. Dignity therapy, primary themes of dignity is generativity. Life has stood for something. That means like when a cancer patient comes to us, we assure him that life is stood for something. You have to live. Continuity of self. Like you have to live long and like you have to play, you have to fight with it. Maintain on one's essence or is intact. Role preservation, being able to maintain a sense of identification with roles previously held. Maintenance of pride, ability to sustain positive self-rate. Dignity therapy means the patient feels hopefulness when we give him therapy, ability to find and maintain a sense of meaning or purpose. He finds himself that like I can live with it and there is purpose in my living. Affirmative concern worries on fears concerning the burden death will impose patient's family also to reduce and cope with stress, lessens chance of relapse. Examines the role of entire family in maintenance of the patient's symptoms, to psychoeducate the family regarding expressed emotions, because sometimes the family doesn't accept these therapies, so we have to educate them that how to behave with the patient and how to maintain the relationship with the patient. Psychoanalytically oriented therapy to effect change in patient's personality structure or character, not simplify, activate symptoms. Improvements in interpersonal trust, capacity for intimacy, coping mechanism, capacity to grieve, and ability to experience a wide range of emotions are so important that aims of psychoanalytic therapy. Now, loss comes the CBT. That is cognitive behavioral therapy, which is very important for a cancer patient to have. It's a challenge to the cognitive distortion and replacement with more adaptive thoughts. The National Cancer Institute funded multiple CBT training sessions for clinicians engaged supportive counseling with career supervisors. The prevalence of these training sessions indicated the growing recognition of the cognitive thoughts therapy is an evidence-supported technique for a variety of people who seek psychosocial interventions. For people with cancer, cognitive behavioral therapy offers a way to cope with the stressors to having life-threatening illness. In CBT, the patient is asked to write down. When we are in the CBT sessions, it usually takes 8 to 10 sessions with the patient. What we do with the patient, we ask them to write down typically distressing thoughts or as they occur. What is the patient intend to have these thoughts? Are these thoughts triggering by certain events? How patient feel when having these thoughts? How does the patient's body feel? What does he usually do to cope up with these thoughts and feelings? Does it work? Exploring this process to change what does not work. And so these are all these things that psychological medicine helps the cancer patient to help to avoid the value of their life. They maintain the quality of life by doing all these CBTs and dignity therapy. Thank you.
Thank you so much, ma'am, for this much needed session on breast cancer awareness. As we all know, we are doing the clinical aspects absolutely correctly, and we are working usually on the clinical aspects. And regarding the psychological aspects, many of us many of us do not take that into consideration. We do not take that much as important as it is. So the psychological therapy, the cognitive therapy for breast cancer patients, that you have talked about in this session. And so thank you very much for this wonderful session you have conducted, Dr. Sadakar. So now moving forward, we have the last session is the preventive aspects of breast cancer. I think most of the things regarding breast cancer have already, preventive aspect also have been already taught in this webinar till now. So still moving forward. So this session, I will be taking this session again. So we already talked about the modifiable risk factors and some lifestyle risk factors. Dr. Shamima already talked about that. So we can skip that now. So what are the preventive strategies we can work in our settings? So the American Cancer Society recommends for all women, we should have approach to have a healthy weight. Physical activity should be propagated among them. Alcohol, as it has been seen that alcohol consumption in Western countries is one of the major cause of breast cancer. So then what is the link between diet and breast cancer? So as we know that healthy diet has a healthy effect on our lives. So same is for breast cancer. Then there are other factors like choosing to breastfeed for more than 1 year. That will lower the risk for breast cancer. Then other preventive strategies for those women who are at increased risk of breast cancer. So there are women who are already at increased risk of breast cancer because of certain factors which they may have in their family or genetic structure. So for them, we have close observation for early signs of breast cancer. Genetic counseling and testing is important. And in some of the Western countries, they are doing prophylactic preventive surgery, that is removal of the breast to prevent the risk of breast cancer. And there are medicines also to lower that risk in those women who have high risk of breast cancer. So what is the close observation is when you have more frequent doctor visits, when you start breast screening at early, you start mammographies. Mammography is a process of breast screening. So you start that mammography early in life when you have at high risk of breast cancer. Then adding another screening test such as MRI for high risk patients. Medicines like tamoxifen, roxafen are given in some parts of the world, but they have their own possible benefits and risks. Then there is genetic counseling, where we counsel the patient who have family history of breast cancer, or they have a family history of genetic inheritance of any gene like BRCA1, BRCA2. So then we counsel them and test them, and further we have to counsel them again, whatever the results are. So that is also more prevalent in Western countries, but maybe in future it will be something that will be done in our part of the world also. Then preventive surgery, like already told, for very high for patients which have very high risk of breast cancer, they can undergo preventive breast cancer surgery. So this was a little bit about the preventive aspects of breast cancer. Then there is screening of breast cancer for early diagnosis and treatment. What we can do to promote this approach, that screening of breast cancer. So for women who are at average risk of breast cancer, and that is who do not have any family history of breast cancer, who do not have any genetic mutation. So for them, what we do between women in age group of 40 to 44 years, they have an option. They can start if they want a mammography every year. But after 45 years, it's recommended by the American Cancer Society that they should do mammography every year. And in 55 and older women, they can switch to mammograms every other year. So screening has to continue as long as women are in their healthy years. So we have talked about clinical breast examination and breast self-examination, but there is very little research that supports that it has a clear benefit. The clinical breast examination or self-breast examination have some clear benefit. The research hasn't shown anything like that. So because usually a woman discovers some abnormality in the breast, that is when she can report to the doctor. So that's how the self-breast examination is not helping much. So but what we should propagate in females, that whenever they see any abnormality in their breast, whether it's some excretion or there is some lump or any other abnormal change, they have to report as soon as possible to the doctor. They should report immediately to the doctor, in fact, so that it will not be diagnosed at a later stage. So American Cancer Society has again recommended for women at high risk, they have recommended some things that we can also propagate in our scenario. So what are who are the women? Like I already talked about this, the women at high risk of breast cancer are those who are having genetic mutation, or their first degree relatives are having genetic mutation, or they have undergone radiation therapy to the chest between the age of 10 or 30 years. And there are certain genetic syndromes which can also prone you to get a high risk of breast cancer. So for them, it is recommended to have breast MRI and mammogram every year, starting at an earlier age, that is 30. So, but the American Cancer Society does not recommend MRI for those women who have a lifetime risk of less than 15%. So there are risk assessment tools for breast cancer who assess how much percentage is the risk in each woman. So if the risk is less than 15%, then you don't need to have MRI, but mammogram should be done at least starting at 30 years of age in those who have high risk. So in summary, what we talked about in this session, that breast cancer is the most common cancer, has also many modifiable risk factors, and screening methods are available if applied properly, may help in early diagnosis and decrease the mortality, especially in the lower and middle income countries like ours. And we need to propagate more of such awareness programs about breast cancer in our community. So thank you very much for this session. Now, Now, we have completed almost all of our sessions. So I would here like to thank, first of all, our worthy HOD, who has a visionary approach towards his team, towards our department, and his visionary approach has always graced our department. So I would like to thank Professor Dr. SM Salim Khan, our dynamic HOD of the Department of Community Medicine. And I would like to thank all the speakers for getting some time out of their busy schedules and being here with us and making this webinar successful. Thank you, all the speakers. Thank you so much. And I would like to thank our worthy Principal, Dean GMC Srinagar, Dr. Tanveer Masood also, Professor Dr. Tanveer Masood also, for inaugurating this session, this webinar session. And so I would like also to thank all the participants for being here, for patiently listening to all the speakers and making this webinar a success in its time. And last not the least, I would like to thank Dr. Wasim for supporting me in this webinar, whenever I had any issues, so he was there to support. So, and I would like to thank all the faculty of the Department of Community Medicine for being there and making all the efforts to make this department shine all through. Thank you, everyone. So
Thank you, Dr. Kausar, for successfully conducting the workshop as a webinar. Thank you very much.